Nutrition Guide for Stroke Prevention. Based on medical research worldwide. Disclaimer and safety information. This information is not intended to replace the advice of a physician or other qualified healthcare provider and is for informational purposes only. Anyone who wishes to embark on any diet, medication, exercise, or other lifestyle modification to prevent or treat a specific disease or condition should first consult and obtain permission from a physician or other qualified healthcare provider. Pregnant women, in particular, should seek the advice of a physician before using any recommendation from this publication. The authors and publishers are not responsible for any injuries and/or damages to persons resulting from this protocol and expressly disclaim liability for any adverse consequences resulting from the use of the information contained herein. Introduction. Stroke is the leading cause of disability and the second leading cause of death worldwide. More than 13 million people have a stroke each year, resulting in nearly 6 million deaths. 1 in 4 people will have a stroke after the age of 25. The incidence of stroke is increasing rapidly among young people. A stroke occurs when part of the brain is deprived of blood and oxygen, which can lead to cell death. This can happen either when a blood clot blocks blood flow to the brain, known as an ischemic stroke, or when a blood vessel ruptures inside the brain, known as a hemorrhagic stroke. Ischemic strokes are much more common than hemorrhagic strokes. When a stroke occurs, time is of the essence. Treating a stroke within 4 to 5 hours is associated with the greatest likelihood of survival and reduced risk of disability. Early recognition of stroke symptoms can mean the difference between life and death. Up to 80% of strokes are preventable. Risk factors of stroke: high blood pressure, smoking, diabetes, obesity, poor diet and physical inactivity, high cholesterol, dyslipidemia, sickle cell anemia, sleep apnea, high homocysteine levels, age, sex, genetics and family history. Recommended nutrients. Magnesium. Magnesium is a mainly intracellular ion that is crucial for cellular energy production and function. Along with other ions, it helps control nerve and muscle cell activation, and is needed for vascular and neuronal health. Low magnesium levels are common in older people due to lower intake, reduced absorption, and increased excretion in urine. Numerous studies have linked poor magnesium status with a wide range of chronic and age-related disorders, including cardiovascular disease, metabolic syndrome, high blood pressure, and stroke. A meta-analysis of 15 observational studies with a combined total of 692,998 participants found people with the highest magnesium intake had a 12% lower risk of ischemic stroke than those with the lowest intake. It was estimated that for every 100 milligrams of additional magnesium intake a day, the risk for both ischemic stroke and total stroke was reduced by 2%. Magnesium intake was not associated with risk of hemorrhagic stroke in 8 studies analyzed. Nevertheless, a study that included 79,429 participants found those with higher predicted serum magnesium levels based on genetic profiles had a lower risk of hemorrhagic stroke. In other studies, low magnesium status was correlated with increased risk of cerebral hemorrhage following intravenous thrombolytic therapy and post-stroke cognitive impairment in ischemic stroke patients. A randomized controlled trial included 291 ischemic or hemorrhagic stroke patients who were given either regular sodium-based salt, a potassium-enriched salt, or a magnesium and potassium-enriched salt to use at mealtimes over the subsequent 6 months. The intent was to increase magnesium and potassium intake to daily recommended intake levels and reverse possible deficiencies. Compared with those given regular sodium-based salt, those given the magnesium/potassium salt were more than twice as likely to have good neurological performance and improved functional outcome at the end of 6 months. Magnesium may also have a role in acute treatment of some types of stroke. A controlled trial in 36 acute ischemic stroke patients with AFib being treated with the antiarrhythmic drug amiodarone, cortisone, found intravenous magnesium sulfate infusions every 24 hours for 5 days resulted in lower levels of inflammatory markers, example C-reactive protein, interleukin-8, IL-8, improved levels of immunological and neurological indicators, and reduced disability, indicating a possible attenuation of known adverse side effects of amiodarone. In general, however, intravenous magnesium sulfate has not been found to significantly improve outcomes in patients who have experienced ischemic stroke. In a randomized controlled trial in 37 patients with severe subarachnoid hemorrhage, magnesium sulfate infusions, 2.5 mg per milliliter at 20 ml per hour, into the cerebrospinal fluid continuously for 14 days after the hemorrhage delayed cerebral ischemia and resulted in improved clinical outcomes and fewer complications. In addition, intravenous hydrogen therapy was found to enhance the benefits of magnesium in this trial. The olive, Olea europaea, is a staple in the diet of many Mediterranean cultures, and olive oil is a primary source of added fat in the Mediterranean diet. Olive oil consumption has demonstrated beneficial effects on blood pressure control. The benefits of olive oil are attributable in part to its fat content, which primarily consists of healthy monounsaturated fat. A 2011 study examining the incidence of stroke among 7,625 older subjects during a median of 5.25 years of monitoring found that people with the highest levels of olive oil use had a 41% lower risk for stroke compared with those who never used olive oil. In a meta-analysis of cohort studies examining the association between olive oil intake and stroke risk, each 25-gram increase in olive oil consumption per day was associated with a 24% reduction in the risk of stroke. Olive extracts may also play a role in stroke prevention. In a 2008 study involving 40 borderline hypertensive monozygotic twins, supplementing food with 1,000 mg olive leaf extract daily for 8 weeks was associated with significant reductions in blood pressure. In a gerbil model of ischemic stroke, pre-treatment with 100 mg per kilogram olive leaf extract resulted in reduced damage to the hippocampal region of the brain up to 24 hours after ischemia, potentially due to its antioxidant activity. Omega fatty acids. Omega-3 polyunsaturated fatty acids, notably eicosapentaenoic acid, EPA, and docosahexaenoic acid, DHA, exhibit a host of protective benefits that could be expected to lower risk of stroke, including anti-inflammatory and cholesterol balancing properties. They also help protect against oxidative stress and promote neuron regeneration and revascularization after stroke. Epidemiologic studies have found that lower blood levels of omega-3 fatty acids, a lower omega-3 index, are associated with increased risk for stroke and other neurological conditions, when compared to an optimal omega-3 index. A meta-analysis of 10 studies involving over 20,000 people aged 35 to 79 years found that higher levels of circulating DHA were associated with a 22% reduction in stroke risk. Each 1% higher increment of DHA was associated with an 11% reduced risk of stroke. These results applied to protection from ischemic stroke only. No association was found with hemorrhagic stroke risk. A randomized controlled trial of 4 grams of isolated EPA per day in high-risk patients taking statins, followed for 4.9 years, found a 37% reduction in incidence of stroke. Maintaining a healthy omega-6/omega-3 ratio after stroke may also be associated with improved outcomes. In a study of 25 older stroke survivors, a higher omega-6/omega-3 ratio was associated with greater physical dysfunction as well as insulin resistance compared with an optimal ratio. A prospective observational study of nearly 80,000 women in the United States found those who consumed fish, which is high in omega-3 fatty acids, 2 to 4 times per week had a 48% lower risk of thrombotic stroke, and those who ate fish 5 or more times per week had a 70% lower risk of thrombotic stroke, while hemorrhagic stroke risk was unchanged. Another study in over 43,500 U.S. men found that even once monthly fish consumption was associated with a 44% reduction in risk of ischemic stroke. A meta-analysis of 17 cohort studies involving over 672,000 people found that higher fish consumption was associated with a 13% reduction in stroke risk and 19% reduction in risk for ischemic stroke. Flavonoids. Flavonoids, naturally occurring substances found in fruits, vegetables, grains, tea, and wine, have antioxidant and anti-inflammatory properties. A 2016 meta-analysis of 11 studies involving over 356,000 individuals found that, compared with the lowest dietary intake of flavonoids, those with the highest intake had a stroke risk reduction of 11%. Additionally, for every 100 mg increase in dietary flavonoid intake, there was a 9% decrease in relative risk for stroke. The AHA recommends a diet rich in flavonoid-dense foods, including fruits, vegetables, and whole grains, foods that also characterize the Mediterranean and DASH dietary patterns. Flavonones, a type of flavonoid found in citrus fruits, may be of particular interest in stroke prevention, as a study of over 69,000 women found that the highest levels of flavonone consumption were associated with a 19% lower risk for ischemic stroke. Another study in over 20,000 U.S. adults found that, over 6.5 years, flavonone and citrus fruit/juice intake were inversely correlated with incidence of stroke, an association not observed for other flavonoids. Homocysteine is an amino acid made in the body from a common dietary amino acid, methionine. High levels of homocysteine damage the endothelial lining of blood vessels and are associated with a 2 to 3-fold increased risk of cardiovascular disease, including stroke. Supplementation with B vitamins, including folic acid, vitamin B9, reduces the amount of homocysteine in the Meta-analyses of multiple clinical trials and studies concluded that folic acid supplementation was associated with a 10–15% reduced risk for stroke compared with not receiving folic acid supplementation. One meta-analysis that included data from 8 randomized controlled trials with a combined total of 8,513 participants found B vitamin supplementation, B6, B9, and B12, lowered stroke risk by 13%. In 7 of 8 trials, the dose of folic acid was 2 mg per day, whereas one trial supplemented with 2.5 mg per day. In all 8 trials, B6 was 25 mg per day and B12 was 0.5 mg per day. Findings from another meta-analysis suggested daily doses of folic acid under 2 mg may be more effective than higher doses. Components of garlic have many properties associated with heart health and exhibit a variety of antioxidant and anti-inflammatory effects that protect against atherosclerosis and hypertension. According to the results of meta-analyses of studies of garlic supplementation, use of garlic supplements was associated with an average 5.1 mm of mercury reduction and 2.5 mm of mercury reduction in systolic and diastolic blood pressure, respectively, and may help support reduction in cholesterol levels.
Vitamin D.
Vitamin D plays a role in lipid metabolism and development of atherosclerosis.
Supplementation may help lower blood pressure in those with vitamin D deficiency and in the elderly.
A 2018 analysis of 19 studies from multiple populations found that lower vitamin D status was associated with an over two-fold increased risk for ischemic stroke, though no association was found for hemorrhagic stroke. A 2019 population-based study involving over 9,300 individuals found that, while no association with low vitamin D status was observed, severe vitamin D deficiency was associated with a 25% increased risk for stroke. Additionally, a study of 982 Chinese ischemic stroke patients found that vitamin D deficiency is common in individuals recovering from ischemic stroke, particularly women and those with more severe stroke. In a study of 240 patients with ischemic stroke, almost 63% had severe vitamin D deficiency, and the incidence of death after stroke was over 2.5 times higher among individuals with severe vitamin D deficiency compared to those without severe deficiency. A randomized controlled trial of 53 ischemic stroke patients with low vitamin D levels, less than 75 mol/L, found that compared with conventional care alone, intramuscular injection of vitamin D3, 600,000 IU, followed by daily calcium, 1 gram, and once-monthly vitamin D3, 60,000 IU, supplementation for 6 months was associated with a 90% higher likelihood of a positive outcome. These results suggest post-stroke vitamin D supplementation may be beneficial for some individuals, although more research is needed. L-carnitine. L-carnitine is an essential cofactor in the metabolism of lipids into cellular energy. 181 In a rat model of ischemic stroke, L-carnitine demonstrated a neuroprotective effect against tissue damage caused by oxygen deprivation. In another rat model of ischemic stroke, pre-treatment with acetyl-L-carnitine was associated with a decrease in infarct size and prevention of ischemic damage in neural cells. A 2019 prospective randomized controlled trial in 100 patients with middle cerebral artery ischemic stroke examined the use of 1 gram per day of oral L-carnitine supplementation in combination with fat emulsion therapy, a key component of nutritional support following stroke that requires large amounts of energy to metabolize. When used in conjunction with standard ischemic stroke treatment, L-carnitine plus fat emulsion therapy resulted in significant reductions in S100B, a biomarker of cellular damage and brain cell damage in particular, suggesting carnitine could be neuroprotective in humans.
Saffron extract.
Saffron, Crocus sativus, is a culinary and medicinal herb that is rich in carotenoid pigments, including crocin and crocetin, that confer a distinctive yellow color and antioxidant properties.
Saffron extracts have demonstrated antioxidant, anti-inflammatory, neuroprotective, and antihypertensive effects. Findings from multiple animal studies suggest saffron and its active constituents may protect against brain injury due to ischemic and hemorrhagic stroke.
In a randomized controlled trial in 40 acute ischemic stroke patients, those who received 400 mg of saffron extract daily, 200 mg twice/day, along with routine stroke care had reduced severity of stroke symptoms after 4 days compared with those who received routine care alone. In another controlled trial, 19 acute ischemic stroke patients received routine stroke care plus 200 mg saffron extract per day and 20 received routine care alone for 3 months. During the first 4 days of the trial, stroke severity was decreased and levels of brain-derived neurotrophic factor, BDNF, a protein that encourages brain cell growth and repair, were increased in the saffron-treated group relative to the routine care group. Furthermore, at the end of 3 months, those who received saffron had lower disability scores and higher functional independence.
Lutein and other carotenoids.
Lutein, a prominent carotenoid found in green leafy vegetables, egg yolks, and some fruits, has potent antioxidant effects. Lutein has often been examined for its role in visual health, but preclinical evidence also suggests lutein and related carotenoids, such as astaxanthin, may reduce brain damage related to stroke.
A review of 24 meta-analyses found increased green leafy vegetable intake is correlated with lower risks of stroke, heart disease, and mortality.
One meta-analysis that included data from 67 studies found higher intake and higher blood levels of lutein were both associated with better cardiovascular and metabolic health parameters, including lower risk of stroke, compared to those with lower levels or intake of lutein. Furthermore, a systematic research review found high dietary intake of several carotenoids, including lutein, zeaxanthin, astaxanthin, lycopene, alpha-carotene, and beta-carotene, were associated with reduced risk of stroke.
Clinical trials are needed to verify these observations. Protein supplementation.
Early clinical data indicate protein supplementation may be beneficial for improving outcomes in patients with a history of stroke who are in an exercise training program.
In a pilot study, 20 people with long-term impairments after a stroke underwent 8 weeks of cycling ergometric training. The participants received either 20 grams of a protein-rich supplement or a calorie-matched carbohydrate-rich supplement.
The protein-supplemented group reached greater aerobic capacity, functional improvements, and total lean mass versus fat mass.
Additional studies are needed to confirm the benefit of protein supplementation on functional outcomes in patients with stroke.